This week we had a very busy week. We started the week off with the Master's MS course, which is basically a course where we bring residents and fellows to come down here and spend it's broken out over 2 full days of intensive teaching, soup to nuts, about MS. And really trying to get them interested in MS and the fellows to really educate them about MS. And it's by far the best teaching course I think the field of MS has to teach the young budding neurologists. When I started out many moons ago, the treatment of MS, there were none. Patients could get a course of Solumedrol or even ACTH that was going to treat an acute attack, but we had absolutely no disease-modifying therapies at the time. Back in the day, if you had it, you wouldn't even tell patients, or you felt uncomfortable telling them that they had a diagnosis of MS because we had nothing to offer them. And when we had our first drug that became available, then it became a conversation that said, okay, well, we at least have a drug. And we had to move away from not telling patients to now telling them, and that has its own issues because the perception of MS at the time was pretty devastating. But over the last couple of decades, we now have many medications and has really changed our ability to communicate with patients so that now we can tell them what we've got, what medications are available, and what we're planning to do to keep this disease under control. I remember back in 1993 when the first medication, interferon beta 1b, became available. It was such a splash, and every patient wanted to get on it. There had to be a lottery to get on it. It was a big deal. I think this is a tremendous time for the treatment of MS, and we're much better at making a diagnosis. We try and treat patients much earlier so that we can actually prevent the long-term disability issues. So I think that doctors going into the field of MS, or even neurology in general, have a much greater understanding and a lot more excitement about the potential of managing and treating these patients. The other side of that conversation is it's a lot of to do these days, because now you have many medications and they require active management. It's not just like, okay, you're good, take the medication, whatever. You got to really watch these patients, and you got to monitor them with MRI scans, clinical visits, and all their laboratory testing, et cetera, else that needs to be done. So it's a lot more management, but it's very satisfying. I think you look at how the last 2 decades has led to these 14 treatments, and we're able to control relapses better. I won't say completely, but definitely better. I think you look at what is the next decade or 2 going to look like for us. We're still not able to repair. We can't fix anybody who's got some fixed deficits at this point. There's this slow, smoldering progression that occurs in the disease, both secondary progressive and in primary progressive, and we're still not yet able to address that issue. So I think all the medications that we currently now have work at the inflammatory phase when people are having these attacks, and we're getting very good and effective at reducing that. But I think going forward, the next 2 decades will really be focused on trying to look at compounds that suppress the progressive phase of the disease and maybe even be able to improve their neurologic function and repair.